Hello, this is Libby Sagara, and welcome to the July meeting of the eConsult Workgroup. We have a great agenda today. We welcome Grace Song from the California Correctional Health Services Department, speaking to her new program with eConsult in Corrections in California. We also have Stan Frencher, the CEO of HubMD, who is supporting this program. In addition, we have Aasta Thielke from the Center for Evidence-Based Policy, speaking to her recent report published by the Milbank Foundation on eConsults, a triple win for patients, clinicians, and payers. We'll spend a few minutes on telehealth policy updates, and we do want everyone on the call today to save the date for November 16th, when we will hold our first virtual eConsult workgroup. Just a recap of the objectives of our eConsult workgroup for those of you who are new to our monthly meetings. We have been around for about 5 years now. We, through the COVID-19 public health emergency, have made a special effort to focus on providing resources to our payers and providers who are doing their best to increase access to specialty care. So with this, we are focusing over the past few months specifically on telehealth triage, a way for us to look at the different modalities of telehealth, perhaps take eConsult as a first step to a referral, transitioning to the different modalities of telehealth, whether they be virtual or face-to-face visits. So with that, I'm going to hand over to our first speaker, Grace Song of California Correctional Health Services, who has recently stood up a program to focus on eConsults specifically for corrections patients supported by the HubMD platform. And Dr. Song will speak today specifically to their eConsult program, although they have been delivering some significant telehealth services over the past few years. We thank them for all their efforts and innovation in this area. Just to get started, there are some key goals that the Corrections Health Services of California has put into place, and telehealth is helping them to reach those goals. First is to ensure timely access to healthcare services. Goal 2, establishing a prison medical program addressing the full continuum of healthcare services. Goal 3, knowing that there is a shortage in specialty care provision in California, being able to recruit, train, and retain a professional quality medical workforce, and with this, supplementing it through telehealth. Goal 4, implementing a quality assurance and continuous improvement program. Goal 5, establishing a medical support infrastructure. And Goal 6, providing for necessary clinical, administrative, and housing facilities for corrections patients. So there are multiple ways corrections patients can access healthcare. There's a primary team supported by CCHS with on-site specialties, off-site specialties supported oftentimes by public hospitals. In addition, as I mentioned, CCHS has supported a telemedicine program offering their corrections patients telemedicine services over the past few years. And with this year, Corrections is working together with HubMD to expand an eConsult program to increase access to specialty care.
The medium time frame was added not too long ago, which is 45 days. And finally, the routine services that requires a patient to be seen within 90 days of initiation. This does not include follow-ups, but just so you have the context of how we approach new referrals and why timeliness is so important because of this lawsuit. We get graded on these time frames. Okay, next slide. So I work with our headquarters contracting team, invoicing team. The majority of our specialty network is put together through HealthNet. They are our PPO plan, as you would say. They contract most of the hospitals and specialty services for us. And then we have some unique contracts outside of this network. So not anticipating the impact of COVID, I was still interested in eConsult because of the high volume of referrals that we have within the prison healthcare system and the inability to get that timely access to care that I mentioned previously. Routine, urgent, medium, all those priorities, large volumes of backlog, and sometimes we were unable to triage what is most important. And sometimes the basic routine referrals would go to the head of the line and the really sick patients would go to the back of the line. And so collectively, it doesn't matter what type of appointment. So I was interested in the e-consult program. I had met with a physician in one of our contracted hospitals who showed it to me and connected me to Dr. Frencher. So Richard J. Donovan was interested. They are very willing partners. They had a significant backlog and a lot of referrals. Next slide. But Dr. Frencher and I could tell you, February 3 was the first day of the pilot. They were engaged in the training, but I don't feel they tried very hard to use this program to the best of their ability. There was just a very low volume of e-consults, and I'll show that to you later in a graph. So we wanted to move on. I didn't want it to just stagnate. We launched one site. I saw a need for another prison to have an external consultant, particularly for transgender care. So reached out to Dr. Frencher and said, could we look at some charts and do some external validation on the clinical practice for some of the providers at that prison. So we launched that one quickly. We did give them the ability to use the program for any other subspecialty, but that didn't take off either. Finally, we approached 2 other prisons, substance abuse treatment facility, SATF, in the Corcoran area, and the California Healthcare Facility, CHCF, in Stockton. We conducted training sessions at both sites, and we were hopeful that we could follow a trend and see reduction in backlogs for those 2 facilities. Next slide. Well, COVID had happened, but it really hit us right after we had those training sessions. So in March 20 of 2020, a memo went out to the field stating effective immediately, all elective procedures and surgeries will be postponed. We also mandated that we only keep absolutely necessary appointments and cancel everything else indefinitely. This applied to primary care visits. We did say try to convert offsite to telemedicine as possible, but soon we also said you need to cancel as many telemedicine as possible, even with primary care, because that meant taking a patient out of their housing unit, exposing to officers and exposing to personnel throughout the prison to bring them to that clinic visit in the telemedicine suite or in front of the primary care provider. COVID, we saw outbreaks in CIM, LAC, Chuckawalla, Avenal, and San Quentin, which is the most recent outbreak. High volumes, significant enough to look at the resources, look at the hospital resources at each facility, look at the EMS system, how that impacted, and of course, reducing the amount of transports off-site. So I went to my boss, Dr. Kane, and I said, what do you think? We had been talking to the field about decreasing aerosolization, looking at the MedNet machines, devices that can aerosolize and spread COVID. And we said, maybe you can use e-consult for pulmonary consults. But actually that didn't seem like enough. We thought maybe we should expand from 3 institutions to 35 institutions. That was not an original work plan. We were going to gradually phase this out one by one, maybe a couple at a time, get to educate the providers very carefully, be accessible for questions, train them well. We didn't have that time with COVID. I literally spoke to Dr. Frencher, I think Thursday or Friday, and by Monday we had, Monday, Tuesday, the following week, we had 2 training sessions for the entire state. Oh, sorry for repeating that, okay. So since then, you can see, February, we had 27 e-consults training with the RJ Donovan group. In March, we added CIM, some of their chart reviews. By April, we had added SATF and CHCF, And that's when we actually launched the training for the statewide. I think some people still were limited because we did not integrate this program into Cerner. So there is a learning curve and there a comfort level trying to get a program that's not in our EMR, printing it, scanning it manually, and putting that into our medical record system. So we did go up in May. We are emphasizing the importance of using this program on pretty much every monthly statewide physician leadership conference we have. And then by June, you can see the numbers jumped up significantly. I think there are a lot of distractions right now. The July numbers have come down, but some of that, of course, is related to people have competing priorities, such as taking care of patients in COVID, and just relearning how to use a program and printing, scanning. Next slide shows you that we put together a program in Power BI, Microsoft tool, to be able to track not only by institution, by month, but seeing what are potentially convertible referrals. Some referrals you would never transition to eConsult, and we don't really encourage 100% going to eConsult, but as much as possible should be converted to eConsult. And we've been putting out reports, and we actually will do more, we'll focus more on making this transition. So you see that pie graph, and we, one of our support staff put this together and said, eConsult is not available for this list of specialties. So we will not ding you for that. But if it is available and it's appropriate, we want you to look at these orders and convert to eConsult and cancel the order, and then follow up and see if the face-to-face is necessary after the eConsult. So the next steps, we really find it imperative to integrate the program into Cerner to get more buy-in, better usage, and accurate medical records. And we developed a 2-year specialty services business plan going to 2022 to really launch this program and increase the access for all providers. So that's what I have to share.
Thank you so much, Dr. Song. And now I'm going to hand it on to Dr. Frencher to continue with how eConsult is being implemented in corrections. Go ahead, Dr. Frencher.
Great, and I can't thank enough, the advocacy and all of the leadership from Dr. Song. I think that, in terms of when we were approached about working with CDCR and working in corrections, it was as a result of an experience we had in the Inland Empire working with some of the jail sites, right, and quickly learning kind of the differences and the similarities across both jails and prisons, and understanding increasingly more about kind of the challenges in addressing care needs within corrections. We've learned a lot from working with Dr. Song and the rest of her team, and continue to try to implement this program, and broaden its scope and its impact, as she alluded to. As you can see here, we leveraged a eConsult platform that we had previously had experience with, both in our implementation in the Inland Empire, and personally as a urologist who practices in LA County DHS. I think I see Paul Gibbony on the phone. One of my first experiences was working with a platform there, using a similar partner in Safety Net Connect. So here you can see a screenshot of the accessibility currently as a third-party platform that the providers within corrections have access to, with the goal of evolving that into an integrated platform similar to what I experienced in LA County DHS to ease the workflow burden on the part of the primary care docs. Next slide. These are some of the specialties that are available, and as you saw from Dr. Song's slide, even with this list of maybe 22, I believe, specialties that are available, there's still a number of areas that we continue to expand in a rolling fashion as we identify particular areas that would benefit from eConsult. As Dr. Song has stated, not every referral to a specialist is expected to go through an eConsult, which may differ from other implementations. As you guys are all well aware, you have implementations within, let's say, the AAMC that tend to encourage primary care docs to utilize it, specifically around clinical questions. and assisting with the care of their patients. While in LA County DHS, it's used both from a clinical perspective as well as maybe care coordination. And so as you see here, we've kind of leaned more towards the former than the latter, with a lot of the primary care doctors having the flexibility to submit an e-consult, but are highly encouraged to do so given the need for patients to leave the facilities in order to get an in-person visit where a telemedicine visit isn't available. The bar is fairly high. In safety net communities that we practice in, certainly we worry about transportation. Well, imagine that bar being even higher in terms of corrections and the resource allocation even being more needed when needing to send a patient outside. So you really want to make sure that the need is there and that we are seeing patients in person when we absolutely need to, and using other virtual care modalities like telemedicine or virtual video visits to address those needs when they're not. And so we saw e-consult as part of a broader approach to being able to right-size the care that the patients receive as inmates in corrections. Next slide. And that workflow we kind of coined as e-consult first, so that when a primary care physician in corrections would see a patient, they'd be thinking first whether or not this is something, if they have specialty care needs, could be addressed by an e-consult. And if that was the case, then be able to submit that e-consult and get a determination from the specialist what types of additional information, testing, and or treatment that could be done, maybe just behavioral modifications. And if ultimately a specialist was needed and available by telemedicine or a video visit, then to use that as the approach. But if they needed a procedure and needed to be seen in person, or if that determination was made, then it would already been going through, or already have gone through, a process of diagnostics that would hopefully mean that that visit would be high value at that point. And so next slide. And so, HubMD, when we partner with our clients, it really was about providing specialists who are smart, brave, and kind. We've seen a lot of different models out there with respect to who are the specialists who provide e-consults to patients. And we take a bit of a hybrid approach, both bringing specialists who have expertise in being e-consultants, as well as doing video visits, but also we're mission driven. As someone who finished my residency and was recruited out here to UCLA to help open a new MLK hospital in South Los Angeles, we search for and try to find physicians who are similar to us, who really care about the safety net, understand vulnerable populations, and understand that in order for us to provide care, we need to use innovative techniques to do so. We believe that every patient should have access to care irrespective of their ability to pay. And so that's why our focus has been working largely in the safety net so that they can have access to specialty care anytime, anywhere. Next slide. As we started to do the implementation of e-consults and CDCR, as you guys have already seen, these are some of the numbers that were previously shown in terms of the ramp up. And I think Dr. Song explained well why we early on saw some of the lower numbers and continue to see an increase. I think that one of the important lessons learned in all of the implementation we've done both here and in other safety net communities is really trying to understand what are the barriers for primary care doctors, both from a technical perspective, but also from a cultural perspective in transitioning to use e-consult as a part of the treatment algorithm, and being comfortable in reaching out to our specialists. And I think a big part of that is making sure you have specialists who are focused on case-based learning and making sure that specialists are encouraging the primary care doctors to use it, as opposed to maybe being judgmental about the types of e-consults that are submitted. Next slide. Here is kind of a result of what happens through some of the e-consults in terms of addressing their needs, referring them to face-to-face, as well as referring to a different specialty. I think each of these outcomes help us to understand how folks are using the modality. I think that in looking at different networks and how primary care doctors have used it, I can say that the physicians within corrections have some of the most robust and even complicated presentations. They've done a great job through Dr. Song's leadership in ensuring that when they submit an e-consult, it really is for the purpose of trying to address a specific need for the patient. And they do a really good job of trying to summarize all that information in a way that specialists can simply reply to an e-consult. I've been pretty impressed with their use of the system. And I think that all goes to a lot of the upfront work done both by her and her team, and our team working with them to ensure that they know how to use it. Next slide. Here's an example of some of the e-consults that you'll see, like within the tool. When we work with the primary care docs, we're always trying to figure out ways in which we can encourage them to provide a good clinical vignette that ultimately has a reasonable reply from the specialist and is timely, typically same day or sooner. Next slide. Here's just another example of one of the cardiology e-consults, and so it just shows an example of how providing some validation for the plan that the primary care physician was going down allows for them not to need to send this patient out to see a cardiologist, but rather be able to take care of them on site. Next slide. All right. So with that, we're happy to open it up for any questions, about how we went about the implementation, or any specific questions about, how we engage with implementing eConsult, both in corrections or overall. Thanks for your time.
Thank you, Dr. Frencher. And there'll be some questions for both you and Dr. Song. Can you hear me, Dr. Frencher? You're on mute, Dr. Frencher.
Yep.
So great. So the first question here is actually from Colorado. We have a good number of attendees from different states on. This is from Didi DePerson from Colorado. She has asked, are all HubMD specialists who are providing e-consult licensed to practice in California?
Yes, they are.
That's helpful. I think that's been a big barrier in California, especially, is just with e-consult spreading across the country. And as everybody knows, it is challenging to become California licensed and Medi-Cal enrolled. So that's helpful to know. The next question from Erin Keeley, who's actually from Canada. She brings up the question, do all the specialists have experience dealing with corrections patients and have a good understanding of what's available and practical?
Yeah, that was something that Dr. Song made sure of when we had these early discussions, in terms of making sure that our specialists were aware of Title 19 and kind of some of the limitations, or at least the choices made from a formulary perspective, or even from a durable medical equipment perspective for correctional facilities. And then frankly, even knowing what are the barriers or challenges in obtaining certain imaging modalities, like facility by facility. I was actually, I visited a few of the correctional facilities and was very much impressed with how much on-site available services there were. And so we've made it a point to make sure that our specialists are aware of what some of those limitations are, but frankly, what is available, because I think oftentimes we made assumptions about what was. And so, we're always in constant contact with our specialists. We have, monthly work groups, and try to promulgate lessons learned as we work with, different facilities within corrections. But that started first with understanding kind of some of the clinical expectations through Title 19, and then of course some of the specific lessons learned.
Thanks. And Dr. Frencher, this is sort of a multifaceted question for you and Dr. Song. The first is, which specialties are being used the most? Do you have that data yet, or is it too early?
No, we have some of that data. And so, what we've seen in high numbers, we've seen a lot of the use of orthopedics and rheumatology in particular. I think in terms of in general, outside of CDCR, we see the traditional dermatology and some others being used. But yeah, that's some of the data that we have early, but given the numbers that we see, it's still fairly early. And we'll see how that matures as more and more physicians use the program.
And the second part of this question is, Dr. Song, do you have any thoughts on just what support you need? What's needed after your initial rollout experience? Is there anything that you can define as things that would be helpful? Dr. Song, you are on mute. If you'd like to unmute yourself.
Sorry about that. Yes, right now I need to go back and look at all the trends, and I've been seeing feedback from our health information management team, the folks that do our medical records, and it looks like we need to go back and train everyone on just some of the basics like closing the encounter. We do give handouts and tutorials, but I get some of the same questions. I'm also seeing some people saying this is not a good program. And when I look at their sample question, it's not framed in the right manner. So, and going back to some of those who might have missed the training sessions, and then giving some better guidance. These questions are good for rheumatology, but these probably will always go to face-to-face, so no need. So getting a bit more granular with the different disciplines will be helpful.
Thank you, Dr. Song. And it's interesting to us as a work group, and we look at this across different programs, is how often or what's the percentage of requests for specialty face-to-face visits that can be avoided through the use of eConsult. Are you capturing that kind of information, like how many visits don't have to take place face-to-face because they've been resolved through eConsult?
I was looking at that regularly because I wanted to show the impact, and it was anywhere from 60 to 64% at one time. So if you think about the total volume, that is a great way to use this program and not have someone directly in front of a specialist. This convinced my boss that this is a great program.
Oh, that is great. Thank you so much for sharing that. And it's going to be very interesting for us to hear over time, since I'm sure you'll see great results. One question that has come out from different conversations is, Dr. Song, do you speak to those who run county jail programs? Or are your best practices being shared with the county systems?
Not at this moment. Right now, we do talk about transfers and COVID, but we haven't talked about eConsult. But there are contacts. I have spoken to folks in LA, San Diego, Orange County, San Bernardino in the past. But I'm happy to share our practices with anybody out there.
That's wonderful. Thank you so much. And we're happy to make connections to you or for you also. We have a couple of guests who are from the Correction Services Canada program, and Erin Keeley can speak to that program along with Harold Boudreau. Erin or Harold, I'm not sure if you want to say a few words since you have some similar findings from your program. You'll have to unmute yourself.
Thanks. It's Erin Keeley. I'm just impressed with how similar the experience has been. So we're just getting our feet wet with eConsult. We lead the Ontario eConsult program in Canada, and we just started. We only have about 200 cases that have gone through. But we have the 64% avoided referrals, which is identical numbers to what you're hearing. I'm really excited to learn more about your professional development and how you're giving feedback both to the specialists and primary care. So as we expand, I would love to reach out to you more and hear what tools and information you have found helpful. Our numbers are growing. We haven't seen the growth in May, June related to COVID. So it'll be interesting to see whether it does increase given we've had a similar response of discouraging face-to-face referrals, and are really excited about the opportunity of eConsult in corrections within Canada, starting in Ontario, but building out to other provinces. We're expecting to move to a national network. So currently our healthcare system is provincial, as you may know, and Claire Liddy and I run the Ontario eConsult program, and we're looking at helping our Corrections Canada have a true national network, which will be fun to develop.
Thank you so much, Erin. And Harold, you're on mute. I'm not sure if there's anything you'd like to share.
No, I think Erin gave a great summary. I think we're still in the initial stages. I think our Ontario program is ahead of the others when it comes to use of technology in general. And Erin did describe there is some data, some small data that they're using it, and they're getting some positive numbers. And we are looking to expand to other provinces, looking at the provincial systems to tie into their e-consult programs as well, but also looking at it from a national perspective to have a consistent delivery model. So we're looking at different options we can. So we're very interested as well as what's happening in the state of California. Any additional information. So again, they're very interested, and we're certainly of interest to move forward. And thank you very much.
Thank you both for joining. We always appreciate your insight. And for those who are new to this group, Briere Institute in Canada has been a longstanding member of our group and contributes a good number of publications that help us to find the data we need. I always look to them for these great pieces of information that they can share. Thank you. With that, I welcome additional questions through the chat feature that we can share with Dr. Frencher and Dr. Song, either during this session or get you the information that you need as a result of our webinar today. But for now, I'd just like to thank you for your time, Dr. Song. We wish you the best of luck in these challenging times. Thank you for all of your work and innovation. And thank you so much, Dr. Frencher. We appreciate your dedication as providers.
Thank you for having us. I really appreciate the time.
Thank you. This is just a quick resource that we will have on our website, and that was provided by Dr. Song's team, Erica Sky, who's on our webinar today, who manages telehealth for CCHCS, just showing the great growth in telemedicine use over the years. So congratulations on expanding the use of telehealth in general. And with that, we want to to make a transition here to hand over to our next presenter. We were happy to see last month this great publication. This title of this publication really caught our eye because this really just conveys the message we as a work group have been working to share over the past over 5 years. So eConsult's a triple win for patients, clinicians, and payers, published through the Milbank Memorial Fund. Today we have Aasta Thielke, who is the author of this report. And so with that, Aasta, I'm going to hand over to you. I think you are unmuted, and so I'll let you introduce yourself. Thank you so much for your time today. Go ahead.
Great, thanks so much, Libby. And thanks to everyone for having me on. I really appreciate the time. My name is Aasta Thielke. I'm a senior policy analyst at the Center for Evidence-Based Policy at Oregon Health and Science University. And I'm happy to share the findings from this work with you. Next slide. So today, I just want to quickly talk about our approach that we took for this work, spend most of our time on the findings, really in the evidence side of things, looking at the effectiveness and safety and what we found, spend a little time on implementation management and reimbursement findings, and then just wrap it up with a couple of considerations that we looked at. Next slide. Next slide. Thanks. So just in terms of some context of where this report came from, as I mentioned, I'm at the Center for Evidence-Based Policy, and as part of our work at the center, we administer the Medicaid Evidence-Based Decisions, or otherwise known as MED project. And MED is a collaboration of about 21 state Medicaid agencies from around the country, coast to coast, and with very diverse states in terms of rural, urban, size, political makeup, etc. So this report was first prioritized and developed by the MED project. The work in MED is funded completely by the state Medicaid agencies, so they prioritized and funded this work. And then the center partners with the Milbank Memorial Fund to take some of the MED work that the MED Collaborative wants to make public and turn it into a policy brief that you all, that Libby shared with you all. So that's kind of the history of how we got to this. So in terms of our report, we focused on 3 main areas. The first was looking at the effectiveness and safety of eConsults, and then wanting to know more about how eConsult programs were implemented and managed, and then finally looking at different reimbursement strategies. Next slide. So to really guide key question 1, the evidence question, and forgive me if I speak evidence jargon, feel free to stop me at any time if I use an acronym inadvertently. So to frame our literature search, we use the PICOS framework, which really just defines what we're looking for and what we're searching for, and put some parameters around that. So in terms of what we're looking for any individuals with barriers to accessing specialty care. In terms of our intervention, what we were focused on, really looking at e-consults that initiated in the primary care environment between a primary care clinician and a specialty provider. And specific, so we weren't looking at ED or inpatient use at all. Comparing to traditional referral or consultation approach, or no consultation or no specialty care, and looking at a wide range of outcomes. So clinical outcomes, any kind of differences in clinical outcomes, and then a lot more process outcomes. So access to care, healthcare utilization, patient and provider satisfaction, any type of cost outcome, and any type of adverse event or harm. And then finally, we limited our search to US only, really for the applicability to Medicaid programs. Next slide. So in terms of our methods, for the first key question, at the center, we have a standard set of core sources that we search for every topic. And that does include Ovid Medline, the Cochrane Collaboration, several other sources, and Google. And we looked back 10 years. So January 2009 up to April 2019 is when the Med report came out early last year, and then we just wrapped up the Milbank report last month. For the second and third key question around implementation and management and reimbursement, we also have a standard set of policy sources and look at state provider manuals, rules, regs, and fee schedules. And then we also reached out to key informants from 6 different programs and delivery systems. And a couple of folks are on the call. So I just want to extend another thank you to Dr. Paul Givney and Dr. Darren Anderson. Again, thank you so much for taking the time to speak with us and help shape this report. Next slide. Great, so diving into the first key question. Before I get into the findings, I just want to, this is, as you all know, there's a lot published on e-consults. And I just wanted to give some parameters about kind of what we found and how we approached our findings and getting to where we landed. With this report, we used a rapid review methodology, which means we looked for systematic reviews, so reviews that try and identify all published individual studies on a topic and come to some type of conclusion. And then we updated those with a search for individual studies. So essentially, hopefully, we've captured all available studies that met our inclusion parameters without having to reinvent the wheel. So we identified 4 systematic reviews. We look at the methodological quality of how both reviews and individual studies were conducted. So we determined that all 4 systematic reviews that we included were of good methodological quality, primarily including observational studies. And then we identified 34 additional observational studies, which we rated 3 as fair quality and the majority as poor methodological quality. And then we also identified 2 additional economic studies, one that we rated as good, and then the other we rated as fair. Next slide, please. As you can imagine, across this huge evidence base, there's also lots of different outcomes. So, and so we categorized everything into 7 different domains. I just want to walk quickly through what those were and what went into what we mean when we use those domains. So safety was really around adverse events and harms. Access to care included things like expedited access to specialists, wait times, time to definitive treatment, and then also the time it took for a specialist to respond to an e-consult. The third domain was patient satisfaction. The fourth was patient-important clinical outcomes. Next slide. Fifth was provider satisfaction, both for primary care clinicians and specialists. The fifth was healthcare utilization, which was a little bit of a catch-all, looking at avoided face-to-face visits, no-show rates, specialist request volume, and a couple of other outcomes. And then cost, really anything on cost. We had 1 ROI study, cost to patients, cost to the system, and also cost savings. Next slide, please. So then this is just to illustrate the incredible variety of all the different specialties that are studied and published that we found, and then also the domains in which those studies are reporting. So across the individual studies, those 34 individual studies that we included, there were 16 different specialties or conditions, and acknowledging that this does include multi-specialty as its own category. And then across this then reports across those studies how many reported on an outcome within one of these domains. And you'll notice that there's only 6 domains across the top. The 7th domain of clinical outcomes, there's only 3 studies that we identified in the area of dermatology, so they're not represented here. And if you could click, Libby, just to show, just next slide, it should go. Just to show that the biggest area was really healthcare utilization. And if you, next slide one more time. And then just looking at the difference, only patient satisfaction was only reported in essentially 3 categories. So a huge discrepancy in terms of what types of outcomes are being reported. Okay, one more slide and then we'll dive into the findings. Oh no, sorry, I have a couple more just to set it up. Yeah, if you could go ahead. So in terms of what we found, so looking across the systematic reviews and then the additional individual studies that we included, there was a total of 131 individual studies. 89 of those were based in the US, and those are really the ones that we focused on. Of those 89, the vast majority were observational studies with retrospective data review, which is just to say that in terms of evidence hierarchy and able to make some causal associations, observational studies have some serious concerns for bias. We found 5 randomized control trials as part of this search, and then 3 economic studies. In terms of where the studies were located, they're really coming from a kind of a small core group, which is kind of to be expected, of different healthcare delivery systems. So over a third of the studies came out of the VA, about a quarter came from the San Francisco area, 11 studies came from the Mayo Clinic, and then 28% were from other healthcare settings. Next slide. Okay, this is the last one before we get into the actual findings. Just to set some context in terms of how we categorize the overall findings of what we do, we use the GRADE approach, which is the grading of recommendations, assessments, and I think determinations to evidence. I didn't get that right. But it's an international approach that's used both in guideline development and to develop overall conclusions for the strength of a body of evidence for a specific outcome. So essentially, for high quality evidence or high strength of evidence, we have confidence that what we're seeing reported in the literature would come true if we implemented a similar policy or program in real life. With moderate quality evidence, we think that the direction, so if something looks like it works, we think that it would also work if we implemented it in the real world, but how well it works or the quantitative value of how many face-to-face visits are avoided, that number would likely change a little bit. With low quality evidence, we think that it's going we think that we'd see kind of a similar outcome if the study was implemented in the real world, but we don't have a lot of confidence that the estimates that that study may make. So say a study estimated 30% reduction in face-to-face visits. If that was implemented again in a different program, we don't know if we'd see 30% or 50% or 10% reduction. There's a lot more wiggle room there. And then with very low quality evidence, we just really don't know. So if another similar program was implemented somewhere else, it might have similar results or it might have conflicting results. So and you'll see this terminology when I walk through the findings. Next slide. Next slide, please. Okay, so then just talking quickly through the different domains and what we found. So in terms of safety, there was 2 systematic reviews that report on this and 8 individual studies. And then across these, there were 7 different specialties. So things like cardiology, dermatology. And when we talk about safety, this is, studies reported on outcomes such as inpatient hospitalization or urgent care or emergency department visits while waiting for care or waiting for the e-consult to happen within or after the e-consult had happened. So either within that window or up to 90 days or after 90 days of the e-consult. 6 of the 8 individual studies that reported on this found that there was no adverse events at least 90 days post e-consult. And so what we found was that there's low strength of evidence that e-consults appear to be a safe mode of managing patients. In terms of access to care, as I mentioned, there's lots of different outcomes within this domain. The 3 main areas were access to specialty appointments, wait times, and specialist response time. And across all of these studies, again, we wrapped it all up into domains. We found that e-consults are associated with increased access to care with a moderate strength of evidence. Next slide. So healthcare utilization, this was the area that was most reported. So of the individual studies that we included, the 34, almost all of them reported on one of these outcomes. This really is the focus of the literature when we're doing our review. Looking at avoided face-to-face specialist visits, looking at specialist request volume, no-show rates, looking at visit completion, services utilization, so looking at emergency department use, diagnostic testing, unnecessary procedures, and then looking at the actual consult time that a specialist spent reviewing an e-consult. So wrapping that off, we found that there is moderate strength of evidence that e-consults are associated with a reduction in face-to-face visits, and that e-consults are associated with an increased percentage of completed specialist visits, so, and that no-show rate. Next slide, please. So then the 5th area was patient satisfaction, and really kind of across all of the studies we looked at, there was at least 90% or greater of patients were highly satisfied with their e-consult experience. And so we found that that was a moderate strength of evidence. And then looking at clinician satisfaction for both for primary care and for specialty care, we found that high levels of satisfaction among primary care and specialists. Again, moderate strength of evidence. Next slide, please. And then the last 2 outcomes, as I mentioned, the patient portion and clinical outcomes, this is an area really where there isn't a lot of literature. There was one systematic review that included 3 studies. These were all in dermatology, 3 randomized controlled trials, and found that there was, within dermatology, there was no difference in the use of e-consults compared to traditional referral systems. So that was a moderate strength of evidence. And then for all other specialties, very low strength of evidence, because we just don't know. We don't have any information there. And then finally, looking at cost, we had 2 systematic reviews report on actual costs, 2 systematic reviews, and a couple of individual studies looking at costs avoided, both for total cost, cost to the patient, and cost to the health system, and then 1 study on return on investment. And so what we found was that there's one randomized controlled trial that looked at this. It was based out of the Centers for Healthcare. Oops, hold on. Dr. Darren Anderson's work out of Connecticut found that there's a high strength of evidence that e-consults are associated with lower cost of care than traditional referral systems, and then for all other specialties, low strength of evidence.
Asta, just to check, I just want to make sure, SR is systematic review, correct?
Oh, yes, sorry, I should have spelled that out. Yes,
That's okay.
SR is systematic review.
Great, thank you.
Okay, so just in terms of the bottom line, this is where we got to with our title. And at least from within Medicaid, or just within the health system in general, there are very few interventions that seem to reduce costs, increase access, and that everyone make more efficient use of resources, and that both patients and clinicians are happy and satisfied with. And e-consults appear to be one of those based on our evidence review. with a big caveat. So this area, as you all know, that this area is rapidly growing. There's more and more information and data being published and available. And what we found was there was substantial variation both within a single specialty. So cardiology, for example, access times, no-show rates, and also between specialties. So being able to potentially pinpoint if there's a specific specialty that you'd want to start first or that would have the most impact, it's hard to do that right now with what we saw in the literature, just because there is such variation. However, looking across all of the studies, we found that most studies had similar conclusions in terms of this win-win-win for patients, providers, and payers. Next slide. So then just looking quickly at some implementation and management, just in terms of considerations and how these programs are structured, and also some of the challenges that might go into this. So some programs have this voluntarily, as we heard, that to use the eConsult program, as we just heard with the California Corrections, and also some health systems are making it mandatory or just part of the workflow, as in the LA County Department of Health. There's different types of platforms, whether it's within an EHR, whether it's web-based, and then how you create that EHR interoperability that we just heard about with the previous presentation. And then what we saw looking across programs is that most programs start small in a pilot or just with a single or one or a couple specialties, and have a slow rollout from there. And it really requires a lot of provider education and TA. I mean, just what we heard previously from the corrections presentation. We also heard, if you go back for a second, that providers need a lot of support and education as part of the eConsult process. So using things like templates and detailed instructions and educational materials that are integrated within the eConsult platforms are helpful. And then finally, establishing some quality assurance or quality expectations around specialist response times and expectations, and doing some type of annual or biannual review about how the system is being used. And then finally, program evaluation was really important, and really we saw all of that in the evidence review, since essentially most of those were some type of program evaluation. Next slide. And then finally, what we found for reimbursement, there's lots of approaches to different types of reimbursement for eConsult. So whether it's, when we started doing this work, the CPT codes for eConsult had not yet been released by CMS. This was highlighted prior to that work. So those came out while we were working on this to create a fee-for-service reimbursement mechanism. Programs also talked about using relative value units to give providers credit for doing eConsults. And then different approaches to conversion. So whether you reimburse providers if a eConsult is converted to a face-to-face visit or not, different approaches there. Some programs are using reimbursement for provider time, either using their current structures, such as the LA Department of Health, LA County Department of Health, incorporating that into current workflows, or using some type of capitated payment, whether this is incorporating into managed care organization contracts, or an example from Oklahoma Sooner Care, which is their Medicaid program. They give 3 different entities. They use an 1115 waiver to provide 3 different entities to create health access networks. One of those is at the University of Oklahoma in Tulsa. And through the administrative funding they received to create this health access network, the University of Oklahoma Tulsa uses that administrative funding to fund their eConsult program. And then finally, the state of Alaska just considers all telehealth mode of service delivery, and they pay in parity with in-person visits. So instead of using the CPT codes for eConsults, they just use standard E&M codes with a modifier. Next slide. So then just a couple of considerations that we had when we were talking about this with our Medicaid partners. First, as you all know, this is a rapidly growing field. The more information that we get, the more information we'll be able to know and help kind of target or pinpoint areas that may be more less applicable for e-consults. The majority of the evidence really comes from retrospective data analysis, which has a whole host of biases. There's very limited comparative data for us to make definitive conclusions about how effective e-consults are to this point. I'm sure more information is coming. As I already commented, there's huge variation within a specific specialty in terms of the effect size, so how much, whether the actual numbers you're seeing, and also between specialties. And we really don't have very much information on actual clinical outcomes. So if this is any different than in-person visits as opposed to clinical outcomes for patients. Next slide. In terms of implementation, this is in the era of COVID. As we heard, this is, I think, really rapidly changing. As you all know, it can be really complex and time-consuming to implement it. It might have to be done slow. Some systems found it helpful to provide incentives for providers to do this. Uptake has been slow. However, again, in COVID, uptake has been much, much quicker. So there might be other types of incentives besides financial ones. We did hear with the previous question, there are some issues in terms of Medicaid with some of the third-party networks using out-of-state providers and some of the regulations that Medicaid or other payers have with needing to register with the Medicaid agency and be in-state. And then finally, just the technical challenges of incorporating e-consults into EHRs or modifying some type of web-based platform. And then finally, next slide. Thinking about reimbursement, when the new codes came up, we heard that there were some concerns about abuse within a fee-for-service system. And so folks can consider incorporating this into value-based purchasing, such as through managed care contracts. We also heard from Dr. Scott Shipman at the AAMC that potentially be helpful to establish which patients this might be most beneficial for e-consult, so such as patients that don't have an established relationship with a specialty provider. And then finally, just acknowledging that e-consults require time, regardless of, if a payer or if a health system decides to reimburse for e-consults that have been converted to face-to-face visits, that there is time involved for the whole process. So with that, I'm happy to take any questions or comments, or feel free to send me an email as well. Thank you.
Can I ask a question?
Libby, are you on? I'm fine with it. I don't know if Libby, you might be on mute.
Oh, I was muted. Thank you so much, Asta. I was muting and talking to you all, and I'm sorry to cut you off, Asta, with not enough time for discussion. I just wanted to know, I will capture any questions for Asta, send them over to her, or you can send them to her directly. You have her email address in the slide that you just saw and in the deck that you were sent by email. I apologize, we've wrapped up. We've come to the end of our time, so please mark your calendars for our virtual workshop, and we will see you next month. Thank you, everybody, for your time, and have a great day.
Thank you.
Thank you.